In medicine, lung cancer staging is the assessment of the extent to which a lung cancer has spread from its original source. As with most cancers, staging is an important determinant of treatment and prognosis. In general, more advanced stages of cancer are less amenable to treatment and have a worse prognosis. The initial evaluation of non-small cell lung cancer staging uses the TNM classification. This is based on the size of the primary tumor, lymph node involvement, and distant metastasis. After this, using the TNM descriptors, a group is assigned, ranging from occult cancer, through stage 0, IA, IB, IIA, IIB, IIIA, IIIB to 4. This stage group assists with the choice of treatment and estimate of prognosis. There are several methods by which this assessment is made. They are broadly classified into non-invasive techniques, which generally involve medical imaging of the lungs such as computer tomography scans and PET scans, and invasive techniques such as biopsy and surgery. Invasive techniques provide additional information because tissue samples can be seen microscopically to confirm presence of cancer cells and to determine the type of lung cancer and its grade. Staging may also be categorized as either clinical or as pathological surgical staging. Clinical staging is performed prior to definitive surgery. It is based on the results of imaging studies and biopsy results. Pathological staging is also called surgical staging and reflects not only the results of non-surgical biopsy, but is evaluated either intra- or post-operatively and is based on the combined results of surgical and clinical findings, including surgical sampling of thoracic lymph nodes. Lung cancer. Lung cancer is responsible for 1.3 million deaths worldwide annually, and is the most common cause of cancer-related death in men and the second most common in women. The most common cause of lung cancer is long-term exposure to tobacco smoke. Lung cancer in non-smokers, who account for approximately 15% of cases, is often attributed to a combination of genetic factors, radon gas, asbestos, and air pollution. The main types of lung cancer are non-small cell lung carcinoma and small cell lung carcinoma, the two being distinguished histologically as well as by how they are treated. Non-small cell lung carcinoma is primarily treated with surgery if feasible, while small cell lung carcinoma is more frequently treated with chemotherapy and radiation. The diagnosis of lung cancer is based on chest radiograph and computer tomography scans, and is confirmed by biopsy. Biopsy is usually performed via bronchoscopy or CT-guided biopsy. Treatment and prognosis depend upon the histological type of cancer, the stage, and the patient's performance status. Treatments include surgery, chemotherapy, and radiotherapy. Pattern of progression. Lung cancer can start in various portions of the lung. From there it spreads in fairly predictable pattern. Typically, if lung cancer spreads, it first goes to close by lymph nodes, followed by lymph nodes further away located between the lungs in a space called the mediastinum. In the mediastinum, the lung cancer tends at first to stay on the side where the original tumor started. Once it crosses the mediastinal midline, it denotes more advanced, surgically unresectable disease. Lung cancer can also spread to distant organs, for example, the liver or adrenal glands, which constitutes the most advanced stage of the disease called stage 4. Staging. Staging is the process of determining how much cancer there is in the body and where it is located. Staging of lung cancer is of paramount importance as treatment choices are often highly complex, even for physicians with much experience in the field, and the options largely depend on the stage of the disease. The underlying purpose is to describe the extent or severity of an individual's cancer, and to bring together cancers that have similar prognosis in treatment. Staging information which is obtained prior to surgery, for example by X-rays and endoscopic ultrasound, is called clinical staging, and staging by surgery is known as pathological staging. Clinical staging is done by a combination of imaging and sampling, or stated differently, non-invasive and invasive methods. Pathologic staging is more accurate than clinical staging, but clinical staging is the first and sometimes the only staging type. For example, if clinical staging reveals stage IIIB or IV disease, surgery is not helpful and no pathological staging information will be obtained. Lung cancer biopsies can be taken for two different reasons: diagnosis to find out whether an abnormality seen on a chest X-ray or CT scan is indeed lung cancer, and what histological type it is. Staging, to find out whether a structure, such as a lymph node in the mediastinum, has already been invaded by cancer or not. However, it is often possible, with proper planning, to obtain both diagnostic and staging information with a single biopsy procedure. There is an extensive array of staging methods available, each with advantages and disadvantages. Many cancer treatment centers review newly diagnosed patients at an interdisciplinary chest tumor board where radiologists, oncologists, surgeons, pulmonologists, pathologists and EUS specialists discuss the relative merits of the available modalities and make a choice by consensus. TNM classification The TNM staging system of lung cancer is T-tumor, T1A, primary tumor is a per-mil 2 current CCM in greatest dimension. T1B, primary tumor is greater than 2 but a per-mil 3 current CCM in greatest dimension. T2A, primary tumor is greater than 3 and a per-mil 5 current CCM in greatest dimension. T2B, primary tumor is greater than 5 and a per-mil 7 current CCM in greatest dimension. T3 size, primary tumor is greater than 7 cm in greatest dimension. T3INV, primary tumor invades the chest wall, diaphragm, phrenic nerve, mediastinal pleura, or pericardium. T3CENTR, primary tumor is